Well, good afternoon, and thank you all for joining today for our 3M Virtual Pulse, where we are going to discuss radiology reimbursement risks and opportunities going forward. Just to kind of kick things off and get things started, just with some housekeeping. If you are having any audio issues, check your audio section in your dashboard. If you join through your computer, sometimes that can get a little testy, so you can always use the dial-in information and your passcode. We encourage everyone to ask questions within the dashboard. There is a question section, and we'll get to as many as we can at the end. After this webinar, in the next week or so, we will be providing a recording of this session, as well as the ability to register for the next. And lastly, we appreciate your feedback. And after the webinar, we will, once we close, it'll automatically launch. So please fill that out. And if you are interested in any type of follow-up, please let us know there. So let's go ahead and kick things off. I am going to pass this over to Russ Cardwell, our VP of Imaging Solutions, who will go over today's agenda, introduce our speaker, and get in on our panel discussion. So Russ, why don't you go ahead and kick things off?
Very good. Thanks so much. Yeah, so this is our second virtual pulse call. The first one we did was summarizing the CMS budget neutrality legislation and the Consolidated Appropriations Act and the impact it had on radiology, which at least for 2021, and had a glimpse of what might be ahead. So that was a very good discussion. We wanted to kind of continue on with that theme of what are some of the reimbursement impacts and different things that could be happening to radiology as the year goes on. There's other legislation out there. So we wanted to focus on a couple things. What's known as the Palma Act, which is Protecting Access to Medicare Act of 2014, which also puts payments at risk. There was some new updates earlier this year, which Dr. Hentel will take us through, and also talk about the 21st Century Cures Act, and which that means for radiology reporting and also patient engagement. So we have Dr. Keith Hentel from Weill Cornell. He is the Executive Vice Chairman of the Department of Radiology, yeah, thank you for flipping that over. So Executive Vice Chairman of the Department of Radiology of Weill Cornell Medicine, and we've had the pleasure of working with him in the past. So Dr. Hentel, just to kind of bridge from that CMS budget neutrality topic and subsequent advocacy by ACR, we know that Palma Act has kind of been long delayed and is expected to have payments at risk beginning in January 22. I believe you've spoken many times on this subject, and I would deem you an expert on this topic. So what can you give the audience a brief overview of what that act was and maybe what some of the most recent legislation was in January?
Yeah, absolutely, Russ. And you know, this, as you said, this is a law that was passed by Congress in 2014, and what it was attempting to do was to create a pathway as an alternative for pre-authorization for Medicare insured patients. And it was, so instead of commercial pre-authorization, the law requires that for advanced imaging services, appropriate use criteria are consulted and that there's documentation of that consultation as a prerequisite for payment for the advanced imaging services. And so, as you might imagine, they picked, you know, the high cost imaging. It's MRI, it's CT, it's some nuclear medicine studies, it's PET. It's those type of examinations that are subject to this. And then as part of the implementation over the years, CMS has further defined this program. And for the initial go live, which as you mentioned, has been delayed multiple times, they've picked 8 priority clinical areas that they're going to be focusing on. And again, these were picked on ones that have high prevalence. And so it is suspected pulmonary embolism, suspected coronary artery disease, shoulder pain, hip pain, head trauma or headache, neck trauma or neck ache. And so these are the areas that as a prerequisite of payment by CMS, the radiology practice has to furnish proof that appropriate use criteria were consulted when ordering. Now, probably a lot of people on this call, especially if people are focusing on informatics, realize that there's a disconnect there, right? It's the ordering provider that's required to do this consultation, but it's the radiology practice that needs to submit this information for payment, and that is sort of a disconnect in the process. But truthfully, it's not that dissimilar to pre-authorization, where it is the ordering practice that needs to start that process. So, radiology practices are aware and familiar with these type of processes, but this is a big change that's coming. Like you said before, right now we're in the educational and operational readiness testing phase. The penalty phase in terms of non-payment is slated to begin this January 1st.
Right. So when you mentioned those 8 areas earlier, the pulmonary embolism and so on, are they the same as originally drafted in the legislation, or did those get changed over the years as well?
The priority clinical areas, if I remember correctly, are not in the legislation. That's in the rules making that CMS has done. But they've remained consistent. And I think, when I was going through, I neglected to mention lung cancer is another one that's on the list. You certainly can apply appropriate use criteria for more clinical conditions than that, but those are the ones that you need to apply it for. And so for the interaction, once that interaction occurs, and what gets documented is you have to document, one, which appropriate use criteria, which system was, what is called the QDSM, or the Qualified Decision Support Mechanism, which QDSM was consulted, and there's a list of qualified mechanisms that you can use, and there are several vendors that have gotten their mechanisms qualified in this space, and you have to document what the outcome of that consultation is, and the outcomes can be one of 3 things. It can be it meets criteria, criteria does not apply, or that it does not meet criteria. And in the early years of the program, the ordering provider is not at risk for non-payment. And there is mention in the legislation that in the later years of the rulemaking, the later years of the program, that providers that are outside of the norm will have to be subject to pre-authorization. But that hasn't yet to be defined.
That's a ways off, I assume, yeah. So you kind of hinted on the penalty phase, and again, from the previous talk, we talked about the budget neutrality and that having about a 4% impact to radiology overall. What would the penalty phase of the PAMA be next January? What does that look like?
So it is always, maybe I think about PAMA too much, and that makes me something about me. But it's always kind of amazed me that there's been so much talk about budget neutrality and the cuts that are coming with budget neutrality, when you look at PAMA, it's an all or nothing. Either if there's no appropriate documentation of these consultations, then you don't get paid for that study as a radiology practice. So, the worst case scenario, if none of your ordering providers use it, you're going to lose 100% of your Medicare reimbursement. And that's a rather large sum for most practices out there.
And certainly, if you're doing the high-end imaging, the CT and MRI and PET, I mean, those are the big dollar ones for sure.
Yeah, I haven't done the gap analysis for my organization in a long time, but when I've worked with organizations, we're talking about millions and millions, in the tens of millions of dollars for certain organizations in reimbursement that's really at risk with this program.
Yeah, definitely. So given your expertise, I know you at Weill Cornell, you started down this PAMA journey many years ago and have just kind of been waiting for it to be implemented or phased in. But you've got, I'm sure, lessons learned. And what would you share with the audience today on things you learned from that, or tips that you would want to share?
Yeah, I mean, I think in terms of implementation, well, the first thing I would say is the hour is getting late. January in terms of IT implementations, as anybody who does IT on the phone, January of 2020 in normal people years happened like 2 years ago. We're really, right, you know, it's probably too late to do any meaningful IT implementation, but there are some things that you know that are really important if your practice is doing this. One, I think like anything, you want to implement a system that's as least interruptive to the ordering provider as possible. You know, there's a lot, you don't want to add burden to your ordering providers, to physicians who are busy taking care of their patients. To begin with, I think that it's very important if your organization is just going under this. This is not, you know, I'm sitting here as a radiologist, and you know, in my world, everything else spins around radiology. But when it comes to PAMA and appropriate use criteria, it shouldn't be a radiology centric program. You really have to do this in a multidisciplinary way and get buy-in from your ordering providers, because there are dangers, right? We were one of the participants in the Medicare imaging demonstration project that Congress ran a long time ago to look at the feasibility of using clinical decision support and appropriate use criteria to ensure appropriateness. And one of the things we learned is that the criteria that we implemented contradicted what we knew and what we did as best practice at our organization. And, you know, that resulted in people losing faith in the entire system. So I think you have to do this in a multidisciplinary nature. You have to really look at the appropriate use criteria that you're going to implement. There's vast differences. So I already mentioned qualified decision support mechanisms, and those are the vendors. Those are the actual tools that people can use that you can integrate with your electronic health record or use in a standalone method. But there's also under the program the concept of a qualified provider-led entity. And these qualified provider-led entities are allowed to author appropriate use criteria or endorse others or modify others. And I mean, you know, because of the fact that we learned so quickly that we really need to do what is considered best practice or else the program falls apart, Weill Cornell Medicine has gone through the process of getting ourselves qualified as a qualified provider-led entity. So we have actually created our own appropriate use criteria program around the priority clinical areas that we are going to use.
Excellent. Now, I know you guys have had a rich experience, and you've been sharing kind of your lessons learned for many years in different industry conferences. So thank you for that.
Yeah, and my other advice is if you're the guy who's implementing it, take vacation when it goes live. You know, get far away, because it is, you know, you really want to do this in a way that's good for patients, but it does, you have to remember, it does add burden to the ordering providers, and us physicians, we really do not like being told what to do. So, you know,
yeah, that makes a lot of sense. I'm sure there was a lot of you know, the challenges you had to work through with those ordering physicians as well. Very good. Well, we might come back to PALMA in a little bit, but let's jump over to the 21st Century Cures Act, not to be confused with the CARES Act. So when did the Cures Act officially get implemented, and how is the radiology community changing its behavior as a result?
Well, I mean, I think that the Cures Act was passed, the 21st Century Cures Act was actually passed by the Obama administration in 2016, and there's various aspects of the law that have been implemented over time. It's actually an interesting law that affects a lot of areas of healthcare, probably most focused on healthcare information and interoperability. And you know, I think there's different timelines for the regulations related to interoperability than there are to some of the healthcare information. And as part of the healthcare information, part of what this law does is require standards in terms of passing information and interfaces and the like. I think, you know, what we're most focused on right now, because this part of the 21st Century Cures Act went into effect in April, is about releasing of information to patients. And you know, you mentioned it in context of radiology, and what the Cures Act requires is that patients are provided their information as soon as it is readily available to them. So for us, and there's been some debate over the years, we have a patient portal that patients use, and I think a lot of practices are moving to the patient portal model. The clarification that was given by CMS and the government recently is that, or at least the way that our teams have interpreted it, our compliance offices has interpreted it and gotten guidance from, is that as soon as those results are available, they have to be made available to the patient in the portal. So there's no longer any delay. You know, we used to embargo the results from the patient portal for depending on the type of study, for 2 days to even 5 days for certain studies, to allow that patient's physician to get the results, to reach out to the patient, to have those discussions. Now that information is available in real time. And even though we're talking about this in a radiology context, this is not just related to radiology. This is related to medicine, period. And people may be familiar with the Open Notes initiative, where physician notes and the information found in electronic health records are made available to the patients to review their actual notes. Well, that's part of this, right? Physician notes have to be made available to the patient when the physician charts in the electronic health record. So the patients are getting now, potentially getting their information long ahead of the rest of the medical team, and it is an interesting paradigm. You know, I think that a lot of it was done and in terms of patient safety, because one of the things I have learned over the years is that there really is no better advocate for a patient than the patient themselves and the patient's family members. So I do think it's a good idea to get that information to the patient, but there are certain logistical and timing issues that sort of opens up multiple cans of worms when we're dealing with.
Yeah, certainly patient portals have gotten a lot of attention, and I think their adoption has grown among patients over time. So I'm guessing you're seeing more patients access their information, be it radiology or otherwise, as you mentioned. So what are you seeing with these patients? I mean, what impact does that now have when you don't have this delay or this embargo time between when, in your case, a final radiology report is ready to when a patient is seeing it on their portal?
So for the first thing I'm going to say to practices that are going through this transition right now is just take a deep breath. You know, I think that the anticipation leading up to this is much worse than the actual impact. You know, going when we first presented this at our enterprise-wide physician meetings, and people were panicked. You know, we can't give that information out to the patient. We can't make results, available immediately. I'm going to get calls all night long. People are going to be reaching out. They're going to harm themselves because they're not going to understand what they're doing. Well, it turns out that, there are some patients, and I'll, give some anecdotes that do act on these things. But by and large, nothing much really changes when you make these changes. And I will tell you, just as proof of this, one of my colleagues at one of my sister campuses reached out to IT just this week saying, "Are you guys aware of the Cures Act? We don't want to do this, but we have to make our reports available immediately. Let's do it." And the IT responded, "We did that several months ago." So, clearly it has an impact, but, I think that overall, and there's actually really good data around the Open Notes initiative that shows that making this information available to patients really does not have a huge impact. It doesn't cripple physicians. It doesn't cripple the phone lines to do it. That being said, there are some things we have to really think about now in terms of doing that, because patients will read their information and they don't have the same ability to understand what you're putting in your notes or what you're putting in your reports. I mean, when we first went live with this, I had a patient where our radiologist mentioned a small micro bleed in the brain on a study that was done, an MR study that was done. These are for those of you who don't know, they occur with age. Sometimes they're relatively common. It was related to a little developmental abnormality. There's really nothing to do for that lesion. It was going to have no impact on that patient. That patient could have lived to 220 years old, and it wouldn't have affected that patient. That being said, that patient saw that they had a bleed in their head, and showed up in the emergency department in the middle of the night, to receive care. And in speaking with that patient's primary care physician afterwards, sort of as a debrief, that was a highly anxious patient. But there are a lot of highly anxious patients out there. I think that by and large, it's forced us to be to try to think of wording things that are accurate, useful for the medical community, but also that are less, that are more patient friendly. And I think the ultimate goal would be that if it were possible, and I know the technology doesn't exist, but in the perfect world, you would dictate a report and that would be translated or would result in a lay letter for the patient, similar to what we do in mammography, where we dictate a mammography report, but there's also a lay letter that goes to that patient, explaining in lay terms what's going on, what needs to be done. Is this significant or not? And we're piloting some of that here in terms of automatic generation of lay letters for certain conditions, but clearly for all reports, that's many years down the line, I would think, quite realistically.
And I'm glad you mentioned mammo, because mammo is a field that has had a 20-year head start, I would say, on most of the other disease orientations to get a lay letter, because I think, and this lay letter concept has been discussed for a while, I would say, at least my awareness of it in the radiology community, but getting to an actual outcome has been a little bit elusive.
Yeah. I think in a lot of ways, the radiology community has led the way on this. Patients have been reading our reports for years.
Yes.
Our reports have been showing up in the portals, even though they were embargoed. They've been showing up in the portals for years. So, my colleagues in internal medicine and surgery are, sitting there sweating as the Cures Act goes into effect, because their notes are going to be read by the patient. Well, been there, done that. You will survive. And
Yes.
They didn't believe me, but they're starting to believe me as we now go through. Now, there are certain exceptions that you can have for this, but all of these exceptions have to be done on a one-off basis. You can't make a blanket exception, except for certain things like mental health care and other things. But by and large, if the information is there, you have to release it to the patient.
Yeah, and that's a good point too. Radiology has led with innovation, obviously on the equipment side, but on the IT side for years. And I think I think it's, you guys are, radiologists are in a good position relative to the Cures Act, because again, it's been some of this information has been out to patients for years.
And I guarantee you, overall, this is going to have a positive effect on the medical record. It is, you have to be much more careful when you know that somebody is reading your report that potentially can be affected by it, right? So, for example, we I think a lot of providers and physicians haven't necessarily proofed their reports for grammatical errors or certain template errors. We've lived with that for years, right? We know that if I think one of the efforts that we've gone through quite extensively in the past few years is making sure that our report templates are not gender specific, because the last thing you want to do is talk about, say, a uterus in a male patient, because I will tell you what happens when you do that. That patient will call you up and say, I think you read somebody else's scan. And you will try to explain to them, no, that language is just in our template. We forgot to take it out. We forgot to change it. There's no way you can convince a patient that you've actually read their scan, nor should we be able to. So I will tell you, we've had to bring back patients. And when it's safe to do so, when there's no radiation involved, we've rescanned them. We've reassured them. So, language can be very important, and accuracy in language is very important in the reports. And I think over time, an accurate medical record is a good, is a good medical record. So I think that is going to be a positive outcome from all of this attention that's going on to the reports and the medical notes and everything that's out there.
Yeah, I was just going to say that obviously in the radiology community, again, leading with innovation, 10 years ago it was pretty common to have transcription staff kind of over-reading, if you will, editing or even drafting a radiology report. And that was kind of another step or a person kind of QAing that step in the process. Those have, by and large, kind of gone away in the radiology community. Some still exist, but obviously many providers have gone to self-editing their own reports, and thereby templates have evolved to kind of improve that. So I appreciate you saying that. So is there other, I mean, maybe you can describe how the reporting process continues to evolve. I mean, obviously you've refined your templates over time to not be gender specific. Are there any other things that you could share with the audience in terms of template refining or whatever that kind of makes the reporting process a little cleaner?
Yeah, I mean, I think that from templates. So first of all, and again, I'm speaking mainly from the radiology practice, but certainly anybody who works in electronic healthcare, an electronic health record knows that templates make your job easier. They're more time efficient. They provide structure to the notes that really make it easier for the rest of the medical community to look at your product and do that. But in terms of what I really think where a lot of attention is going is around this are we creating too much work for the physicians? I don't want to date myself, so I'm not going to, but I certainly started long before the age of templates, and even to this day, I still prefer to dictate freeform. Not that I do, but I still, given my choice, I would dictate freeform because that's the way that I learned to think. But templates help organize the record, help organize your product, and the literature is not equivocal, right? It's been shown that other non-radiologists like to read a structured report. Where I think it's going now, and where a lot of efforts are going now, is to creating these structured notes the most accurately and most efficiently by automatically embedding information into the note. So for me, using an example as a radiologist, if that patient comes in and gets IV contrast as part of the exam, why should I have to look that up and then insert it into my report, right? That should come straight from the injector into the report, and I should just review it and sign off on it. And the same thing for medical notes, right? It is silly for a primary care physician to have their office weigh a patient to take the blood pressure, and then for them to have to look at what was written down and then type it into the note. There is technology. All of that information should flow into the note where then it's assigned. And currently, not everybody has that technology, and it's going to take a while for that to become more pervasive. So one of the compromises has been medical scribes, where you have people who are responsible for taking that information and pre-populating it into the notes, so there's less burden on the provider, because it is hard being a physician these days, right? There is so much that you have to do that takes you away from that interaction with your patients that really that is not good, so the more you can do to get that time back with your patient is a really good thing. And that's where I think the field is going for us. And one of the things that we've done in radiology to try to decrease the burden of patients reading their own reports is at our practice, we have a very robust radiology consultation service. So if a patient has a question about their report, or they don't understand something, or they don't understand what they're supposed to do, we actually provide a number to patients that they can call and get either speak to one of our nurse practitioners or nurses that specialize in this, or in some of the cases, if it's beneficial, get transferred to a radiologist who can help you with the problem. So, I think there's different strategies that are going along with some of these requirements that different practices can utilize.
Well, that's a great idea, talking about the phone line to call into, because again, I think with patient portals and more patients reading their reports, it comes to reason that you'll get more phone calls and more questions. So having a service like that, I'm sure, is a great service to your community. Yeah, and again, this kind of goes into that discussion about patient engagement and kind of what the Cures Act, I think, was intending, right, is to get patients more engaged in their own care. So very good. You touched on a topic about radiologist or physician burnout in general, and there's been a lot written about it in the last couple of years and presentations about it. Would you say the Cures Act and PAMA is adding to that burden, or there's other technology improvements that are softening the blow? Like, how would you comment on that?
I think absolutely both. So Palma absolutely is adding to that burden. Ordering providers are going to have to use IT systems to do decision support. And truthfully, especially in a specialized practice like my own, most ordering providers really do know what they're doing, and they do act in the best interest of their patients. So, potentially if I did decision support and they had to answer questions for every single order that they put in, that's a lot of time spent on decision support with I would argue maybe not all that much benefit for 90% of the cases. And you can bet, it adds up over the day. If each decision support interaction takes 1 minute, that adds up over the course of a day when you're seeing patients every 15 minutes or even at most every 30 minutes. The other thing is that that's in the best case situation, right? In the worst case situation, you don't have an embedded product in your EHR, and you have to go log into another system and type in the information that's not going over automatically. And you can imagine how much time that's going to take. And it may not, this is just one little thing, but it's one little thing with lots of other little things. There's all documentation requirements that people have to do and many regulatory things that they have to do. And every little thing that takes away from your time with the patient, is something that is detrimental. The Cures Act, I will tell you, probably causes more patient dissatisfaction before it actually gets implemented as people worry about it. But I think that people are, right now really focusing on their notes and spending extra time on their notes. And I know for a fact that most of my colleagues who see patients don't finish all their notes while they're with their patients. A lot of them go home and take care of their families and then log back on to our electronic health record at 9 o'clock at night and finish all of their notes so they're ready to go the next day. And without a doubt, that takes its toll and leads to physician burnout. I don't think anybody thinks that the electronic health record has been good in the terms of physician wellness and
Sure.
happiness.
That makes sense. And again, some of the other technology tools you talked about, again, just coming back to radiology, where if contrast information can be just put in the report directly, that's a time saver. So there's, I think there's tools that continue to evolve to kind of offset some of those impact of the Palma Act and other things. So I think that's just kind of like how we see things evolving in the industry. But very good. Lisa, can we open it up for questions now? I think we've kind of gone through some of the main topics we intended to here.
Yeah, absolutely. We do have a couple. We certainly appreciate all the information that you both went over. So the first question that we have, and I appreciate this one from Cynthia about, God forbid if something does happen where if something gets into the patient record that shouldn't, for whatever reason, are there contingencies for portal access to patients with accurate information? So I think, is there kind of a fall safe so if somebody gets somebody else's information?
It does, that is not even a hypothetical situation. That does happen where for whatever reason, people can get the wrong information or there can be typos that are, there are really significant typos in reports, when, not to put Russ and 3M, all the 3M people on the spot, but, speech recognition is not 100% accurate. And it's pretty good now and certainly much, much better than when it started. But sometimes certain words like no get left out, and there's a big difference between there is and there is no. And there are ways that once it's in the medical record that you can go and adjust that. There are certainly patients have the option of contacting us, and they do. I speak to lots of patients where some of these issues occur, and you can actually amend the chart. But we do have to be careful, right? Because it's not, with these new timelines of the release of information, the patient may very well see this report before the referring or the ordering provider, who in the old world used to call us up and say, hey, can you correct this before it gets to the patient? I mean, just to show you a discussion that I was part of recently, showing you some of, overall, I'm a big believer in release of information to the patient, but you know, just to show you one area where I think this could have a real negative effect on patients and patients' families is, you know, ICU notes. And in the intensive care units, things change with patients so frequently. And, you know, to have a family or even a patient looking at their own chart while things are going on in real time in a setting like the ICU, I don't think is good medicine or is good for anybody.
Great. Another question that we had coming in said that we all watched in March 2020 as New York had a surge in the COVID cases. Can you share how you have kind of weathered that initial COVID storm and what the situation looks like today?
You know, I mean, I can start with today in New York. I'm happy to say today is my organization's lowest census of COVID patients, really, and as long as I can remember. It's certainly trending down, not only at my institution, but really across New York as a whole. You know, we at one point in time, we had to react to the COVID crisis, and much of our outpatient practices, if you know, the vast majority of our outpatient practices were closed down, and our physicians and support staff redeployed to taking care of acute COVID patients. We had, you know, we converted outpatient space to inpatient, and even acute care settings such as ICU settings that didn't exist before, and we stood those up in record time. You know, I'm quite frankly really proud of my colleagues and the teams that I work with across our organization in the way that we were able to do that. You know, we are hopefully moving in the right direction now. Are my, you know, and I'll speak for imaging right now, are my volumes back to where they were prior to the COVID pandemic? I'm happy to say they're pretty close, but that's sort of misleading when I say that, because in order to now see our patients in a way that maintains social distancing and allows for adequate cleaning, I operate my practices and my resources about 400 something more resource hours a week than I did before COVID. So what that means is our days are longer. We operate, you know, we operate most of our sites. We always operated our sites from 7 a.m. till 10 p.m. We are doing more of our sites from 7 a.m. to 10 p.m. We are now operating almost every one of our sites 7 days a week. And, you know, that continues to take a toll on us because, you know, someone has to staff those hours and someone has to cover those hours. So we're still working our way out, but we're adjusting to the new world. And I have to say that, you know, I think most people here are very optimistic right now, and, you know, get my plug in for people to get their vaccine. If anybody's, you know, on this call that hasn't, you know, is considering getting a vaccine but hasn't done it yet, you know, I you know, really think it's a great thing to do. And I think that is ultimately what's going to help us turn the tide on this whole pandemic.
Great. So we have a couple more questions. So does appropriate use criteria and clinical decision support affect emergency room patients?
Yes. So that's a really good question. And the answer is yes. Actually, I should have mentioned that when I went through the program. There's a lot of rules around this program, and as Russ has sort of alluded to, I could speak for hours and hours and hours on that, but I'm sure nobody wants to hear me speak for hours and hours and hours. But I should have mentioned that these rules have to be used for outpatient care and emergency department care. And while there is an quote unquote an exemption for emergency care that has to happen on a case-by-case basis, and CMS has been extremely clear that you can't just say I work in an emergency department, so therefore I am, you know, I can use the emergency exemption. What the emergency exemption is for is really is really for that patient that gets wheeled in, and you know, you're just going to throw them right on the scanner and image them, because any delay may have an effect. Now, so what that means is that's why you really have to, and I know I've said this already, you know, what our appropriate use criteria program has really been engineered to do, and we've been, you know, obviously had the advantage of working on this for years and years and years. I think I started doing decision support at Cornell in 2011. But we've really engineered it to be as non-interruptive to physicians as possible. So we do mine information from the electronic health record. And if we've mined enough information to know that that order is appropriate, we don't even interrupt the physician. They don't even see the fact that decision support has fired. If we need more information, we may ask a question. If it's not appropriate, we may make a recommendation. But, you know, looking at that and looking at the appropriate use criteria and estimating how often it's gonna fire and how often your physicians are going to be interrupted is really, really, I think, important. You know, tied to delays in care, tied to also tied to physician wellness and well-being.
And Dr. Hentel, I mean, I think, again, one of the premises behind PAMA and order appropriateness was the standard of care. Just as an example, I think if someone had chest pain and showed up in the ER, they got a chest CT, and that may or may not always be the right, you know, course of care, right? And that, I mean, of course, that's a big expense, and I think that's kind of where the industry was looking to address. Is that right?
There's no question that there is no question that there is overuse in certain areas of medicine. And if you look at the use of imaging by geographic area, you know, this hasn't been published recently, but whenever this does get published, there's big variations in utilization of imaging in the Medicare population based on geography. But, you know, the goal is, you know, and what, you know, when I first went into decision support, and my mantra was just give as much as it can, throw it all out there. I like, now I talk about that as the shotgun approach. And I've learned that you know, there's not a lot of good appropriate use criteria in imaging for all clinical conditions. And we've pared it back. Now, I'd like to think that as opposed to a shotgun approach, we use a very surgical approach now. So not only are we picking the clinical areas where or imaging exams where I think we have the opportunity to actually improve care, and not using decision support unless required by the law in those areas. So not only are we only focused on the areas where we need to do it, even within those areas, we only offer decision support for those cases where we think we have evidence-based recommendations that can improve the care or improve the safety of the imaging. So I'd like to think we've gone from very blunt to very, very sharp and very surgical over the 10 years that I've been doing this.
I'm guessing, again, when you started down this journey with PAMA, I mean, and though it's been delayed, these are some of the examples of the learning opportunities you've had over the years, right? To become more surgical with how you design the rules, right?
Yeah, I mean, you really do. And I can tell you one, you know, patients are patients. Patients are all unique, and it's very hard to fit every patient into a rule. And, you know, I still remember my frustration when we first implemented our decision support as part of the Medicare Imaging Demonstration Project. The RAND Corporation had to send a nurse to come validate our decision support and make sure that it was working. And, you know, we had concerns because I was learning in real time at that time that it's very hard to apply decision support criteria to every patient. So they sent the nurse. First patient that went in flowed through perfectly. The criteria fit perfectly. The second patient that came in, the criteria fit perfectly. So I said to the nurse, I said, these aren't real patients. And she said, no, they're real patients. I said, there's no way. Third patient flowed through perfectly. At that point in time, I cried foul again, and I said, there's no way. And finally, after, you know, our several more patients, she admitted that these patients were reverse engineered from the criteria. Patients are not reverse engineered from criteria. And I think one of the things I love about the Cornell criteria that we use for some of these conditions, which I'm not aware of in other, you know, QPLE's criteria, is that we admit that there are times when it's just too complicated for a computer or a rule to predict what the best thing for this patient is. So the outcome of those interactions is we pop up our consultation service number and say, call us. We will answer the question, but we're not going to be able to answer it, you know, using the decision support rules. So at the end of the day, you want to do you know, you really do want to provide that best care for that patient, and that's really what the program is intended to do, and what I believe that my group has really focused on doing.
Very good. Lisa, is there one or two more questions we have?
Yeah, and I apologize if my screen kind of keeps glitching around. If you're able to see that, I'm not sure what's going on, but it kind of has a mind of its own today. So I apologize if you're able to see that. But yeah, let's do one more question from Kim. In regards to CDS, will it only be for certain diagnoses that were discussed prior? I was under the impression it was for all MRI, CT, PET, and nuclear medicine procedures.
So that is there are nuances to this, and I will try to simplify it as much as I can. So it is for all in the legislation. It is for all advanced imaging services. Is what the law actually says. So CMS has interpreted that as the question says. It is for all imaging criteria, but unless if it's any clinical condition other than one of the ones that have been designated as priority clinical areas by CMS, an appropriate response from the system is that AUC do not apply. So for us, if we do an MRI, say of the elbow for elbow pain, that's not one of the appropriate use criteria. So for us, we're not gonna, unless we have a rule that things can really improve the care, we're not gonna fire decision support for that case. We're going to let it flow through. We're gonna let the order flow through, and then we will code that in a way that's gonna document that appropriate use criteria does not apply. So our interpretation of the regs is that yes, you have to, for all CMS patients, you have to put that documentation of the consultation, but the order has to go through that system to determine whether or not it applies or not, but you don't have to apply decision support. Now, if the system doesn't know, if you just put in an MRI of I'll use an MRI of the brain. Well, that may be for headache and it may not be. So one of the first decision points is if someone puts an MRI of the brain in and we don't know whether it's for headache or not, that's the first question that we're going to ask. Is this for headache? If they say no, well, then they don't. We'll just score that as appropriate use criteria don't apply if we don't have another criteria that we think helps it. So technically, yes, but there's going to be a lot, at least in our program, which is very surgical, there's going to be a lot of orders that go through as appropriate use criteria don't apply. And I know from 3M, there's probably a lot of people who have coding expertise on this webinar. I think maybe you should probably by now be familiar with how CMS has come up with the way that this has to be submitted as part of the standard CMS claim process through a combination of a G code. So CMS has created a list of G codes corresponding to each of the qualified decision support mechanisms, and a HCPCS code that there's 3 HCPCS codes. Appropriate use criteria doesn't apply, adheres to criteria or does not adhere to criteria. So that was a very long-winded answer, but it's actually a very complicated concept that a lot of people don't. It's very complicated and it's nuanced, and there is still a lot of confusion out there. When I go around and speak to practices and consult with practices on this.
I would agree. I mean, even just listening, and I know you mentioned about the lay letters, but even just listening to all of this for somebody that is in these hospital and practices settings, I'm sure it is sometimes, deer in headlights, drinking from a fire hose of information. I guess with that, I mean, do you have kind of any advice, kind of final thoughts before we go ahead and wrap up as far as, the solutions that you have integrated within your practices and, for those that are on the phone to kind of take things, obviously one step at a time, as you said, take your breath, but do you have any kind of final thoughts on or words of advice for those that would be looking to start implementation and get things going for them?
So for the Cures Act, that's here already. So I mean, I think that for an organization, you have to work with your compliance office. One of the things I didn't mention, I know we talked a lot, and Russ started this session with talking about penalties. For each case that you don't comply with the Cures Act, so if you withhold information from a patient that deserves to have that information, the penalty for each case is $1 million. So this is not something that you really, you know, and that sounds scary. CMS certainly has not started going after people on this, or the OIG or any of that. But for now, you know, there are severe penalties to that. So work with your compliance office. You know, there are nuances to the regulations that can you know, let practices work up to this. But this is here, and it really needs to be dealt with with whatever technology you have in place right now. For Palma, it's also getting late. So if you're part of an organization that does imaging, you know, if you're not, don't have imaging in your practice, but you refer for imaging, you know, make sure you work with your imaging groups to understand what this is going to require as we go into 2022. If you're part of an organization that does imaging, really, if you haven't started already, find people who understand this space, and you got to come up with a solution that can be implemented by 2022, because as of now, CMS has not indicated that they would be willing to extend the operational readiness and education period further than where we are today. There's so much to this. Like I said, I can talk for hours and hours and hours and hours and hours and hours on this. And, you know, so, you know, find people that are knowledgeable about this. There is a lot of information that's out there on this. You know, I think there's information in the literature. I know if you just, there's in the scientific literature, there's information from the ACR, there's information from CMS on this, but you know, really start to investigate this, because that is coming, and coming rapidly.
Absolutely. Well, thank you so much, Dr. Hentel and Russ. I do want to thank everybody for joining today. As a quick reminder, we will be sending out an archive of this webinar in the next week or so, where you can actually register for our next session that's going to be coming up in August, where we're going to be hosting Charleston radiologist and radiology and imaging in Texas. So it'll be another great session where we'll continue conversations like this on really what's important to radiologists and imaging practices. Again, we really would appreciate if you want to fill out that survey, just so we know how you thought about today. But also, if you are interested in learning more about our solutions, you know, please fill out that survey and let us know. Russ, is there anything you'd like to close with?
Just a sincere thank you to Dr. Hentel for sharing his insights. He's got a lot of experience in these topics, and again, I think shared really great information. So thanks very much, Dr. Hentel.
It's been a pleasure, and you know, speaking with you today, and working with you over the years. You know, I think that IT and these solutions done right really can be beneficial. So I think it's partnerships like this that certainly help us move the bar forward.
Thank you very much. It's been great.
Yep. Thank you both so much. Have a good rest of the day.
Yep. Bye-bye.
Bye, everybody.